All right. Hello, everybody. I know we already have a lot of people online, and hopefully a few more will join. Meanwhile, my name is JP Lopes. I'm a clinical immunologist at UH Rainbow Babies and University Hospital Cleveland Medical Center in Cleveland, Ohio. And it is a pleasure to be here to moderate the first combined webinar between CIS and NICER. Several of you, by proximity of coming to this, will be either part of the two societies or know about the two societies. But if somebody is strictly in one of the societies and not fully aware of the other one, so CIS Clinical Immunology Society, which I think the large majority of you will know for sure. The webinars organized at CIS like this one that we're doing are organized by the Early Career Immunology Committee that I'm a part of. Part of our educational opportunities, and CIS has so many other areas that you can participate in terms of education and research, including our annual meeting coming soon in Minneapolis in the beginning of May. And NICER is the North American Immunohematology Clinical Education and Research Consortium, which has a lot of people, again, that overlap with CIS by obvious reasons because of the type of topics that we're talking about. That has a lot of educational and research opportunities, as the name indicates, and we're always looking for new partners and people with an interest in immunohematology to join us, the ones that are not already part of this as well. NICER also has a webinar, a monthly webinar case conference in similar terms with a couple of differences from the one that I described for CIS. So we're trying to combine to the best of our abilities so that it's similar to what we do on both societies, but it may look a little bit different if you're just used to participate in one of them as well. We'll have a single case, but hopefully with a lot of good discussion coming through in the setting of the collaboration between societies. The case is also a collaboration between institutions and multiple people. In that same topic, we'll have a case presented by one of our residents, Dr. Delena Nguyen, is an excellent internal medicine resident at our hospital that will be applying for a fellowship in allergy immunology coming this summer. So I'm sure several of you will see her around, and it will be great to see a familiar face. And she'll be presenting at CIS as well, so we'll have one other opportunity to see her soon. But the case, the patient in cause, is a patient that was taken care of and continues to be managed by Dr. Natalia Chaimowitz, that I just saw joining us as well at Cook Children's in Fort Worth, Texas. So it also brings some collaboration. And then we're lucky enough to have with us great senior faculty to comment on the different aspects of the case. So we have Dr. Josh Milner from Columbia, the Division Chief of Pediatric Allergy Immunology and Rheumatology, and the Chief of Allergy Immunology and Rheumatology Services of New York Presbyterian Morgan Stanley Children's Hospital in New York City, which I'm sure a lot of you know as well. And Dr. Kelly Walkovich, the heart and soul of NICER, so great participation for this overlapping consortium. And she's the director of the immunohematology program at University of Michigan, where she wears several other hats and it's proficient clinical immunology doctor there as well. So without further ado, I'll let Delena start. I'll be moving the slides, Delena, so just let me know whenever you need me to move through for any of them if I'm not getting the flow. We'll have several instances during the presentation where we'll try to stop to ask people if they have questions, but you can place your questions in the chat or the Q&A area. If you place it in any of those, just please try to change from the default option that is to send it to hosts and panelists to send to everyone so everybody can see your questions, and then we can talk through them in any points where we stop for that as well.
All right, great. Thank you, Dr. Lopez, for that introduction. As you said, I'm Delena Nguyen. I'm an internal medicine resident at University Hospital's Cleveland Medical Center, and I'll be presenting this super interesting case that Dr. Chaimowitz saw at Cook Children's Medical Center in Texas. Next slide, please. So our learning objectives for today are to recognize different causes of neutropenia and its management, and also to identify different genes with presentations with different microbial etiologies and associated autoimmunity and allergic disease. Okay. So the case that we have here is a 13-month-old previously healthy child who presents to the ER with a 4-day history of fever and a new skin lesion as pictured here. Regarding his past history of infections, really just remarkable for molluscum. He doesn't have a history of recurrent sinopulmonary infections, ear infections, no chronic diarrhea, blood in the stool, or other GI infections. He also does not have recurrent fevers or lymphadenopathy to suggest an underlying autoimmune pathology, and no prior hospitalizations due to infections or autoimmunity as well. Next slide, please. Review systems is also largely unremarkable. Specifically, it's negative for abdominal pain, failure to thrive, oral ulcerations, gingivitis, dysmorphic features, or skeletal pathology. His past medical history is notable just for mild eczema treated with PRN triamcinolone, and he also has food allergies to egg, dairy, and peanuts. Of note, he also had normal newborn screening. For his family history, his father has asthma, but there's no family history of recurrent infections, autoimmune, or other atopic disease. For his social history, he lives with his mom and dad, does not have any siblings, and does not go to daycare, so he may be exposed to fewer pathogens or infections than some other toddlers his age. But his vaccines are up to date, including 3 doses of oral Rototec. But he had not yet received MMR and varicella, as he had presented just before his 1-year wellness check. On exam, he's ill appearing. He has that ulcerated lesion that we saw with the black S scar on his trunk, and he has no lymphadenopathy or splenomegaly on exam or imaging, which was not obtained. Next slide. In the ED, his CBC with diff is notable for leukopenia with severe neutropenia and an ANC of 259. He also has mild anemia in the setting of infection. And you can see here, there's no other cytopenias. And of note, his absolute eosinophil count is 0, which is why it's not pictured here. Right. His wound and blood cultures grow Pseudomonas, which is consistent with that lesion of ecthyma gangrenosum that we saw a few slides ago. And so I want to stop here and ask the audience what your thoughts are on the presentation so far, and what's on your differential, and what would you order next to work it up?
And just a reminder, if you put it in the chat, that just switch for the options sent to everyone instead of just host and panelists. If you send to host and panelists, I'll do my best to try to read through the stuff that you write. So I see bone marrow biopsy coming along, and somebody that second that. I read Coombs test. Any other ideas? I'll give you a few more seconds through it, or we can continue talking about it. Peripheral smear, equals neutropenia and autoimmune neutropenia workup, flow cytometry, lymphocyte subset like T-cell functional testing, quantitative immunoglobulins, previous CBC reports, gene panel for neutropenia, basic immune evaluation. So lots of options that will fall in line with what we'll see next, or good suggestions overall. Somebody asked about any hot tub exposure. Not to the best of my knowledge, Nettie. I see you're on. Any spa days for the baby, or nothing that you can think of? If she's close by, she may be connected but not listening. But when we talked about the case in detail, there was not like a clear exposure of that type to go into that as well. And Scott Kenna was also suggesting LDH aldolase and S100 proteins. Go ahead, Nettie. Sorry.
Can you hear me now?
Yeah, we can hear you.
No. All right. No hot tub.
No hot tub. Okay, perfect. So these are great suggestions. I know it's pretty early in the case, but thanks everyone for the participation. So we'll move on to see what was done next, with a few disappointments from some of the stuff you recommended there, but they're great suggestions for sure.
Thank you, everyone. All right, so next, I want to ask Dr. Walkovich what your differential is for his neutropenia, and would you pursue any additional workup on this patient, and if so, what?
Sure. Well, I love most of the recommendations that were coming in. I would, if you're able, to take a look at the CBC itself, because there's a little bit more information as a hematologist that we usually dive in. So obviously it's quite stunning that the ANC is 259. That's too low, well below the 500 mark for severe neutropenia. But if you look a little closer there, you can see that there are bands, which is the next most immature form. And in fact, you have a measurable absolute immature granulocyte compartment, as well as several monocytes, which is indicating to me that the marrow space is intact and likely is able to produce granulocytes, which I think is very important, particularly in the setting of an infection where you may have either infectious suppression or immune-mediated clearance. Additionally, if you look up at the hemoglobin, it is just a little bit low, but the size of the cells are normal. That is potentially consistent with a chronic inflammatory process, but would raise the question of the utility of when the bone marrow timing should take place. If you were more worried about an infiltrative process, whether it's an infectious infiltrated, or there weren't a lot of signs for malignancy, but that would have to be considered as well, or a bone marrow failure, which again, it seems like the marrow is functioning at least to some degree. But if you're going to blame a lot of this on true inflammation that's chronic, the platelet count is very normal for that scenario. It's 191, so that's not so helpful. So I'm actually kind of suspicious about whether the bone marrow, particularly for this age of patient, is just not able to make neutrophils to get to the capacity that's needed to fight this infection, because you do have young forms and you have a lot of clearance. But it's hard to assume that that would be the diagnosis, so we most certainly would do a good hard look at a peripheral smear to make sure that the neutrophils look normal in content. They have granules. There's not a specific granule defect or some other visual defect that we can pick up. We would also get quantitative immunoglobulins up front. And probably as a first pass, we are pretty aggressive with both genetic testing and other immune diagnostics up front, but I'd love to see a little bit more of the initial workup before proceeding or subjecting the child to a bone marrow.
And we'll move to those next as well. There were a couple more suggestions as we were talking through as well. Like Kay was saying, they've seen similar presentation in an XLA patient. Somebody suggesting IgM as well, which is part of what we talked before, like was type of presentation for was XLA, and I think that's a suggestion, oxidative burst as well. And then I was saying that with biocytopenias and the XML, that they would also consider an occult presentation for leukemia ALL as well. So we'll go through with a little bit more of the workup that was done.
Great. Thank you, Dr. Walkovich, for that astute breakdown of the CBC. So hematology is consulted during the admission, and their primary differential at the time was myelosuppression due to severe infection, congenital neutropenia, which seems less likely as it would be expected to present sooner with severe infections, often in the first month of life due to bone marrow failure. As well as common things being common, autoimmune neutropenia or chronic benign neutropenia. And the anti-neutrophil antibody comes back positive for this patient, suggesting possible autoimmune neutropenia. Next slide. So immunology is consulted as well, and over the next few slides, I'll go over the immune evaluation, starting with the immunoglobulins here, and you can see that there's elevated IgE and mildly reduced IgM, but normal IgA and IgG. Next slide. T-cell phenotyping is also performed, and initially there's some T-cell lymphopenia, and reduced CD4 counts, but that normalizes on repeat several weeks later outside of the acute infection. Of note, B-cell phenotyping and lymphocyte proliferation testing has not yet been obtained, as the family had been lagging on getting some of the tests. So unfortunately, we don't have that data to share today. He also had pneumococcal titers obtained and received a Prevnar 13 vaccination with a very good response of 11 out of 13 antibodies, which in the setting of a protein antigen vaccine is a reasonable surrogate for no major T-cell dysfunction in the absence of other T-cell function testing, as well as the ability of his B cells to produce specific antibodies. All right. So the patient is treated with cefepime and discharged on ciprofloxacin, and he recovers quickly with the initiation of antibiotics, and there's no other complications during the hospital stay. The decision is also made by the hematology team during that admission to start the patient on GCSF, given the Pseudomonas infection and the eschar to promote wound healing. And he has an excellent response to this and normalization of his neutrophil count. So I'll ask the audience here, with the new data that we've seen, if you have any other thoughts on the differential now and on next steps to take.
And before reading some of those, like echoing, because Kelly wrote in the chat that like for mutations like Elaine, often apparent in the first year of life, but just keep in mind that several of the other congenital neutropenias do not manifest or are not recognized until later. So sometimes patients with Thrushman Diamond or Wee-Morgetta2 can have a little bit of a delay in some of these diagnoses. Emma was asking, just came to us in panelists, probably see what you think about that, Kelly. She's saying, Emma was asking about anti-neutrophil antibodies, PPV, and negative predictive value for autoimmune neutropenia in somebody's age.
Yeah, I don't know if I have those values off the top of my head, but we have a little bit of like a love-hate relationship with the anti-neutrophil antibody because it's so calming to get the positive assay back. And when it fits the story, it feels tidy, but it's not the greatest assay. The sensitivity of the assay is only about 80% and the specificity is only about 60%. So it's actually pretty unreliable. There are many of my colleagues who will argue that it shouldn't even be used upfront at all because it's very challenging to interpret its clinical value. There are plenty of cases that are published where actually patients with Elaine variants or severe congenital neutropenia have a positive antibody and their actual genetic diagnosis was missed for several months to a year, leading to complications. So short story, if you send it and it fits your clinical picture, great. But I certainly wouldn't make a strong conclusion on just the basis of the anti-neutrophil antibody being positive. And I see Ashish comment in the chat. He is right. So most patients, particularly for autoimmune neutropenia of infancy, which is what I think we're trying to talk about here at the moment, versus autoimmune neutropenia that occurs at older ages, which is clinically a distinct entity. For autoimmune neutropenia of infancy, these patients should come without any infectious etiology. You can still have immune clearance, but it's not the same sort of clinical entity where we would expect full resolution and no clinical infections.
And we've seen in several of those suggestions that we saw that before as well. I just remember a kid that we diagnosed with was XLN as an example. That was also like anti-neutrophil antibody positive as part of their workup, but then with other genetic causes. So that's very good. A few other suggestions of what people were writing about their differential were things like somatic TLR mutation, X-linked neutropenia with a positive anti-neutrophil antibody, just similar to the case I was talking about. Commenting on generally consider autoimmune neutropenia to be a benign disorder in young children, and convinced that that is the cause, and not convinced that that is the cause for a patient like this. And if there's IgG and low IgM, whether it could be Wiskott-Aldrich, and things in that range as well. Trying to keep up because you guys are greatly participating to make sure I'm hoping I'm not forgetting any of the stuff that you guys wrote through it. Somebody's commenting that autoimmune neutropenia can still lead to infectious predisposition, even if it's not, especially if it's not like the mild benign neutropenia we're talking about. But I think that's where the nomenclature, as Kelly was saying.
Can I just clarify? Because I think there's a lot of syntax problems in the field of neutropenia, and so people get a little turned around. And so there is a distinct entity like autoimmune neutropenia of infancy, where it is usually a screening CBC for iron deficiency that prompts the blood draw. Patient is clinically well, they have no clinical features of neutropenia, and it should spontaneously resolve. Only about 10% of those patients ever need intervention with GCSF or antibiotics, and most of that is sort of cautionary than truly mandated. There's a separate autoimmune neutropenia that is much more associated with either underlying IEI or even if it's not genetically recognized, that is a setup for infectious complications and is much more problematic. There is a sort of a third condition that is not felt to be immune mediated, but is chronic benign neutropenia of childhood, which muddies the water for everything. So just those are like different buckets that patients should be put into whenever you're trying to gauge the risk for infection and what you need to do going forward. I was also very curious about the dose of GCSF that was used, because at this point the patient hasn't had a bone marrow, but you can infer a lot about how well the bone marrow functions based on the dose of GCSF that was required to normalize the neutrophil count.
I don't think we have that in the subsequent slides. Natty, do you remember the dosage of GCSF that they were using?
I want to say the dose was 5, is it mics per kg? Does that sound in the ballpark of a GCSF dose?
Okay.
Yeah, so that's a relatively hefty dose. It's sort of the standard oncology starting dose, but often true autoimmune neutropenia of infancy gets by with a whiff. Like
Okay.
0.5
Much lower dose.
mics per kg, yes, and you have to space it out. So understanding how much GCSF you're giving and how that's impacting the bone marrow can also help you infer the functionality of the marrow and what might be happening from a clearance immune-wise or not.
And I think that this is kind of like a follow-up for you as well, Kelly, because the discussion in the chat right now is would others feel comfortable to start GCSF in this child without the bone marrow exam? That in general, several people are writing. They would do a bone marrow before going for GCSF.
The primary reason to do a marrow prior to initiating GCSF is if you have a strong suspicion of a malignancy, where the GCSF would drive the malignant clone, particularly a myeloid clone. In this clinical setting, I would say there are many providers, including myself, who wouldn't necessarily go to a bone marrow upfront and would feel comfortable with a test of GCSF prior. Okay.
And I see like mixed opinions there, so I guess
it is
amounts to that as well.
Because you do have technically a bicytopenia, so it is a little bit tricky there. I could see it being appropriate either way in the algorithm.
With a mild anemia as well. Okay.
Yeah.
Okay, perfect. All right, Delena, back to you.
I think we've touched on a lot of it so far, but I was going to ask Dr. Walkovich what her thoughts were on the use of GCSF on this patient, and in general, what criteria you would use to decide which neutropenic patients would benefit from GCSF.
I think when you have a kid that has severe neutropenia and a marrow that looks, best as you can tell, is functional with immature grands, and you have an active infection, it's very reasonable to trial GCSF.
Great. And what about recommendations for going to the ER in case of fever and or the use of prophylactic antibiotics?
Yeah, there's no consensus on this. I think in a child that many people have flagged in the comments, they're worried about an underlying immune deficiency. It may not just be a pure phagocyte or neutrophil defect. I do think until you have a better handle on definitively the marrow function and where the other aspects of the immune system are that might increase the infectious risk, it would be reasonable to counsel the family to go to the emergency room for subsequent fevers after they're discharged from this experience.
Thank you. We can move forward now. So the patient is discharged and immune workup is ongoing as an outpatient, including genetic testing and specifically the in vitae inborn errors of immunity and cytopenias panel. And I think the real kicker to the case is the identification of a pathogenic variant in the CART11 gene. And the variant here denotes a nonsense mutation, stating essentially that at nucleotide number 1893 on the coding DNA sequence of CART11, there's a substitution of guanine for cytosine, and this results in tyrosine at amino acid 631 being changed to a stop codon. All right, next slide, please. And this slide shows the more detailed genetic testing report, and I want to bring to your attention specifically the second bullet point, which in summary classifies this variant as pathogenic and relevant when homozygous in the setting of autosomal recessive CART11 loss of function, but not in the setting of autosomal dominant CART11 related conditions that I'll soon describe. So even if it doesn't explain his current clinical or laboratory phenotype, his carrier status is still relevant for any future children that he might have. In addition, even though this specific variant is listed as pathogenic by in vitae, we didn't find any publications that list this specific variant or position on the coding DNA sequence of CART11. And the 3 papers that are quoted in ClinVar supporting this variant classification as pathogenic by in vitae are broader papers on autosomal recessive CART11 loss of function that lists other relevant truncating mutations. We did, however, look at different in silico algorithms, with several suggesting that this variant is deleterious, with a combined annotation dependent depletion score of 28.5. But there are other algorithms that also classify the variant as likely benign. So I think that there's more nuance to this testing result than meets the eye. Okay, next slide. So just quickly putting on our molecular biology hats, CAR11 is an important scaffold protein downstream of protein kinase C in lymphocytes. And when lymphocytes are stimulated through their antigen receptors, CAR11 associates with BCL10 and SMALT11 to form a complex known as the CBM complex that ultimately promotes lymphocyte activation and proliferation through the release of NF-kappa B heterodimers into the nucleus for target gene transcription, as well as through activation of the JNK2 and mTORC1 pathways. Next slide. This is a schematic of the CAR11 protein, and I want to highlight that most reported dominant negative variants are found in the CARD, latch, and coiled coil domains in the N-terminal half of the CAR11 protein. Though you can see in the blue here that there's a few scattered dominant negative variants in the C-terminal half as well. And this is important because mutations in these domains disrupt CARD11 conversion from a closed inactive form to an open scaffold that can recruit cofactors to form a signaling complex during T-cell receptor signaling. So I'll stop here and ask you, Dr. Milner, what do you make of this specific variance, given that it is outside of the domains that most dominant negative variants are found?
So a couple of things. First, just thanks for the opportunity to be meeting with you folks. We have a somewhat analogous consortium in the New York region called New York Royal. And so when we heard about NICER, we thought that was like a response because you're in the Midwest or something, but I do believe that we're all good friends regardless. But it's great that you guys are doing this, and I think we all need to be doing this more in this type of a venue. You know, there are a bunch of different things that come up just about the genetic report. A reminder that when it says pathogenic or likely pathogenic, they're talking only about a variant. They're never talking about the context of the disease. And so they could be referring to a dominant disorder or a recessive disorder if they say pathogenic or likely pathogenic. The other thing is that they're using as the criteria for pathogenic is that this is a truncation mutation, but they're not telling us but that does not make that true. So you can have a truncation early in the protein that just cuts it completely, and you have haploinsufficiency, and that is overwhelmingly likely to be pathogenic for a recessive disorder. But you could have a truncation later on in the protein, further down, like right where we're looking right there. You could have a truncation that cuts off just enough to interfere, but not enough for it to be missing. And so those may be pathogenic in different ways, or they might not be pathogenic. Maybe you don't need the end of the protein there, right? And so I wouldn't assume that it's pathogenic when something is truncated, unless you have seen people who have truncations that far along in the protein. And you know, I think if you look, there are some slightly later truncations that were reported that are in association with autosomal recessive CARD11 deficiency that leads more to a severe combined immune deficiency type phenotype. But the potential certainly exists for this to behave differently than if you were just completely missing the protein. That's the important point. So it actually, though, also means that it doesn't matter where the domain is. So if you had because it's a truncation, if the truncation was in the CARD domain or coil domain, you would never get dominant negative activity because the protein's gone. So the fact that the truncation is later on here, the question is whether it's going to lead to haploinsufficiency or actually have a dominant negative effect. That's really what the question is. And so, you know, I think there are multiple levels of confusion created by the way that this is reported, and I think it's important to say that straight out. And so now, okay, we're treated with a somewhat terminal truncation in card 11, and the question is it dominant, negative, or is it haploids, which could potentially be, therefore be causative and cause what this patient has, because absolutely autoimmune neutropenia and high IgE alone is more than enough to absolutely be like almost pathognomonic for card 11 dominant negative mutation. There are many presentations that could be pathognomonic, but if you have a high IgE with no good explanation, which he doesn't, at least at this point, and a presumed autoimmune neutropenia, that's been one of the most common presentations that we've heard about, or it's found. But one has to prove that this is dominant negative. So obviously, one of the biggest questions I would ask is, does either parent carry this?
Which would be a great question, but without the answer yet, because there was no parental testing, right?
And so, meaning like as a reflex with something like this, I would be checking the parents. It's still possible to be a completely asymptomatic carrier of card 11 dominant negative mutations. It is entirely possible. It's also possible that a parental carrier could have subclinical neutropenia and you wouldn't even know about it. And so the but if neither carried and this were de novo, then I would have a very high index of suspicion that this is pathogenic. So that, I mean, that's we can talk about what would we do further than that, but that would be my initial impression of it. And just for completeness, it's possible. Like I said, you could also have a gain of function from a truncation. It exists, such things exist. We haven't really seen much evidence for that. And so I don't think that we would be in the benta space, or we've actually now started to see some other types of gain of function mutations in card 11 that lead to an inflammatory autoimmune cytopenia type phenotype, not with allergy. But I don't think that these types of truncations would ever lead to, it doesn't seem like to gain in function. So just for completeness.
And it can never be separate from his clinical and lab phenotype, of course, because that's the crucial part, as you were mentioning. But can you comment further than whatever in vitro or other companies report in commercial testing like this one? How do you play into your suspicion as well different scores in silico models, especially for genes like card 11 that can go LOS, NOS, AR, AD?
I don't.
Okay.
I really don't. The odds are, the higher those scores are, the more likely that it's pathogenic. Again, you don't know if gain or loss, right? The higher those scores are. But I find for these purposes, for precisely this question, essentially useless.
Okay. In the chat, Natalia had confirmed family had refused parental testing, and Joao was also adding that it's important to keep in mind that in silico predictors are even less reliable for dominant negative or gain of function production.
I mean, not even, they aren't predictive. Essentially, yeah. I mean, there are some experimental in silico predictors of gain of function, but we have a ways before those are close to being ready. So it's more that there's the possibility that this could be linked, and I don't have proof to the contrary, that this could be dominant negative, so that I would want to continue on. And again, if it were de novo, that
change that around.
Really, that would be almost now you're guilty until proven innocent in terms of the variant. If it were de novo, I doubt it is.
Or in silico, we'll continue trying to work on making artificial intelligence more intelligent, but we'll move on, Delena. We'll move on to the next one.
I do want to just point out one more tool, which I don't know why they wouldn't put it in here, is that if you look in Nomad, the Nomad database, you would find a whole slew of truncation variants that are there, all the way across, that can be helpful. But nonetheless, their PLI score, which is a way of predicting how many truncations would we expect by chance, And are there fewer than that? And for CARD11, there are far fewer truncations than would have been predicted, suggesting actually that a truncation mutation is selected against. A recessive truncation mutation is selected against. And so we may not know the whole story here, I guess.
Okay, awesome.
Great, very interesting. Thank you, Dr. Milner, for that context. So this slide here demonstrates the potential changes in CARD11 activity and associated clinical phenotypes. At the far left, where CARD11 activity is essentially absent, patients have a severe phenotype of combined immunodeficiency, whereas patients with milder decreases in CARD11 activity have a more variable infection risk, as well as a tendency towards atopic disorders, as we've kind of alluded to, in a condition called cadence that I'll discuss shortly. And then at the other end of the spectrum, patients with gain-of-function CARD11 mutations with excessive CARD11 activity can develop a condition called benta that I'll also discuss. And even though they're displayed separately, there have even been mixed phenotypes reported, including a variant in CARD11 resulting in a mixed cadence benta phenotype. And as research on CARD11 continues, I think that this gradient will continue to be populated with additional clinical phenotypes and disorders, though definitive genotype-phenotype correlations may be nebulous, as Dr. Milner and his colleagues pointed out in one of their papers on CARD11, likely reflecting the influence of modifier gene mutations and environmental factors that influence syndromic features, as noted for other primary immune regulation disorders. But I think that this simplified version is a good place to start. Next slide. So starting at that far left of the prior figure with absent CARD11 activity, germline autosomal recessive CARD11 loss of function mutations cause a severe phenotype of combined immunodeficiency characterized by early severe infections, opportunistic infections, including PJP pneumonia, hypogammaglobulinemia, abnormal B-cell differentiation, and deficient T-cell function. It can, however, be distinguished from SCID by normal lymphocyte counts and is not detected by newborn screening, which may lead to delay in diagnosis. Left untreated, patients with CARD11 deficiency typically die of respiratory infections at a young age, and given the severity of the disease, hematopoietic stem cell transplant might be considered in these patients. And in fact, 2 patients have undergone successful hematopoietic stem cell transplant. Next slide. Heterozygous gain-of-function mutations, on the other hand, in CARD11 cause spontaneous aggregation and constitutive activation of NF-kappa B, which, as you can recall from earlier, plays an important role in lymphocyte activation and proliferation, and results in a disease called benta, which stands for polyclonal B-cell expansion with NF-kappa B and T-cell anergy. Patients present with peripheral B-cell lymphocytosis comprised primarily of naive and immature B cells and persistent lymphadenopathy and splenomegaly since infancy, sometimes associated with autoimmune phenomena and cytopenias as well. The degree of susceptibility to infections is variable, and affected individuals may have frequent sinopulmonary and ear infections with poor antibody responses to certain pathogens and vaccines, likely in part due to intrinsic B-cell defects in plasma cell differentiation and reduced memory B cells. So even though there's an excessive amount of them, the B cells aren't necessarily functioning properly. In addition, mild T-cell anergy may explain increased susceptibility to viral infections, though T-cell numbers are usually normal. Next slide. Heterozygous mutations that result in a dominant negative effect over the wild-type CARD11 protein can interfere with the ability to activate downstream CBM complex-dependent signaling pathways like NF-kappa B, JNK2, and mTORC1, like before. And in a paper by Dr. Pomerantz, Dr. Milner, Dr. Snow, this disease is termed cadence, or CARD11-associated ATP with dominant interference of NF-kappa B signaling, which is what we'll adopt here. And even within this umbrella of cadence, different mutations have varying degrees of dominant negative effect on multiple CARD11 signaling outputs that can also affect the phenotype. So that further complicates that initial paradigm that we saw between CARD11 activity and the various clinical phenotypes. However, most individuals do suffer from severe atopic disease with peripheral blood eosinophilia, elevated IgE, and variable infection risk as well, with a predilection for cutaneous viral infections and respiratory infections. In addition, autoimmunity and neutropenia have been seen in 20 and 14% of patients respectively. Although keep in mind that these tables and the data that are displayed are from 6 years ago, so the number of patients described has increased through time and may change some of the proportions as well. And as a side note, I wanted to bring up some interesting data showing that the CBM complex also promotes T-cell receptor-induced uptake of the central amino acid glutamine through the surface transporter ASCT2, which also links antigen receptor engagement with mTORC1 activation. And T cells of patients with cadence have been shown to exhibit defects in upregulation of ASCT2 and glutamine import that plays a role in Th2 skewing and this predisposition towards atopic disease. In vitro studies in which T cells were cultured in excess glutamine as well as NF-kappa B activating cytokines actually partially restored T cell receptor dependent proliferation, mTORC1 signaling, and interferon gamma secretion, providing support for a possible treatment strategy by supplementation with glutamine, which requires CARD11 for import into T cells. So I wanted to elaborate here a little bit about why CARD11 is associated with ATP. So several monogenic primary atopic disorders have been described with varying forms and severity of allergic inflammation. And the pathogenesis typically involves a skewed Th2 profile with excessive secretion of IL-4, IL-13, and IL-5, as well as eosinophilia, elevated serum IgE, and abnormal mast cell degranulation. And defects in NF-kappa B, JNK, and mTORC1, which are those signaling pathways influenced by the CBM complex, can promote Th2 skewing in mice models. Germline heterozygous loss of function mutations in CARD11 have been shown to have a variable degree of negative dominance over the wild type protein in human patients, as we saw, leading to a variable clinical phenotype of immunodeficiency and dysregulation with frequently described allergic manifestations. And this is in contrast to the total lack of functional CARD11 protein in B and T cells in human and mice models, which completely prevents any activation and differentiation of effector cells that are needed for the development of ATP. Next slide. So I'll touch here on hyper IgE syndromes. In 1966, a syndrome with recurrent sinopulmonary infections, staph abscesses, and severe eczema was described and called Job syndrome. And later, when an associated increase in serum IgE was described, this became autosomal dominant hyper IgE syndrome and is most commonly due to variants in the STAT3 gene. Many other genes since then, including CARD11, have been described in patients with immunodysregulation and immunodeficiency kind of under this umbrella of hyper IgE syndromes, and they have very diverse clinical presentations and lab findings. Next slide. Back to our patient here, if you could also click again, Dr. Lopes. You can see that he develops worsening disseminated molluscum, seen here all over his trunk and his upper and lower extremities. And dermatology is consulted, but it spontaneously resolves over the next 12 to 18 months. So I'll stop here and ask the audience if this disseminated viral infection changes your views on his possible genetic diagnosis.
It's a slightly unrelated question in the chat because it's not fully directed at the images we have, but Sabia Hannes was asking if in this patient it was gain of function or loss of function. So we're not sure. I'd like Dr. Milner correct me if it's wrong, but I would suspect more loss of function in the setting of dominant negative than a gain of function.
The question is it there's almost no way it's gain of function because of mutation like that. The question is whether it's a dominant negative mutation or a less important haploinsufficient one, and we don't know the answer to that, but we can get into that a little bit more. But I'm happy, you know, from my perspective, the emergence of the molluscum doesn't change my suspicion of regarding the variant. Regarding the variant, it obviously makes me assume there is an inborn error of immunity, but it doesn't change my concern for working up the variant.
For the specific variant itself. Okay.
Okay, we can move forward then. Something notable I also wanted to talk about in his labs was that even though his absolute eosinophil count in the ED initially was 0, looking at the trend of his AAC, you can see that he's had intermittent eosinophilia up to nearly 1,600 without any secondary causes like helminth infections or medications, etc., to explain it. And so though this is in the setting of atopic disease, his eosinophils are higher than expected given the burden of his atopic disease. It may be a feature of underlying cadence, like we discussed before, though this can't really be distinguished clinically. And even though he doesn't have any signs or symptoms of hypereosinophilic syndrome, it's important to monitor his eosinophil counts longitudinally and to monitor for any evidence of end organ damage due to eosinophilia or myeloproliferative disorders. Slide. I wanted to return to the slide on cadence again to highlight that eosinophilia and cutaneous viral infections, including molluscum, HSV, VZV, and Kaposi, are commonly seen in cadence patients in about 2/3 of the patients, according to the data here. And I was going to ask Dr. Milner if this finding of disseminated molluscum changed your opinion on the variants, but you already answered that question, so thank you. So the patient is continued on GCSF 3 times a week and is eventually weaned off after about a year of therapy shortly after his 2nd birthday. His ANC counts have remained over 1,500, and his last ANC is 2,380 in November of 2023, which was also the time that his GCSF is stopped. The family, unfortunately, hasn't gotten any labs drawn since the GCSF was discontinued, despite prior attempts. So this is the most recent data that we have.
I was just gonna add what Kelly was writing in the chat because it's important in the setting of our prior table that GCSF can cause that can result in elevated absolute eosinophilic count. So it's not just assuming it would be the single cause, but it's important in this case because he was on it.
Good to know. Thank you. So on the topic of neutropenia, I did want to circle back to Dr. Walkovich and see if, given these genetic testing results, what do you think now about his neutropenia and what additional workup would you do or how would you approach managing this patient?
And I think it could be a good point, Kelly, if you're able to share your slides. I'm just going to quickly stop my sharing so that she probably can give her answer with what she had prepared for us. Thank you.
Sure, just let me get it to presenter mode. You guys good?
We see it now, yeah. Thank you.
Perfect, yes. So thank you. I love this topic, the intersection of neutrophils and IEI. So I might not have a clear answer for your particular case, but I think there's an increasing appreciation that neutrophils are key immune mediators. We all have known their storyline about antimicrobial functions with microbe detection and phagocytosis, degranulation, the production of reactive oxygen species, and net formation. But there's an increasing realization of the role that they actually play in the adaptive immune system through their immunomodulatory effects with cytokine production, antigen presentation. And in fact, when we look at the full spectrum of IUI that was listed out in the IUIS, which is what that bar graph in the middle is representing, the different categories within the IUIS, my colleague Tom Mishniaki looked at patients enrolled in the USIDNet registry just to see how many of them had neutropenia as a recorded finding, and actually well over 10% of patients had it. And interestingly, most of them weren't in the congenital defects of phagocyte function or number. A lot of them were hiding out in the combined immune deficiencies, the antibody section, or defects of cellular humoral immunity. So they are seen throughout, and neutropenia should really be a red flag for folks to take just a moment to pause whether or not there are other underlying features where you would be more triggered to have a lower bar to send immunoglobulins, Team B subsets, genetic testing, et cetera, even functional testing to try to identify or uncover the II, because often neutropenia can be the first sign, but it also heralds a worse outcome for the patient. It's also interestingly a little confusing, particularly from this study, to figure out how much of the neutropenia is exactly related to underlying biology that the genetic change is manifesting versus a reaction to the increased infection risk or medications that are used. So that's really hard to tease out in most cases. There are a couple classic II that have well-known associations with neutropenia, and I thought it would be helpful for the group just to see the spectrum. Everything from CVID, which has a very low rate, sort of 1 to 8% reported, all the way through ADA2, X-linked agammaglobulinemia, hyper-IgM, GATA2, Chiari-Higashi, to WHIM syndrome, which is near universal. So for some disorders, many of them are ultra rare. Neutropenia is a finding that's there almost all the time, but some of our more commonly encountered IIs, it's more rare. And these are due to multiple different strategies. There are problems in, for sake of time, I'll just click through these so folks can kind of see them in one. But there are 3 kind of buckets of problems that indicate problem with your reserve or your ability to make more neutrophils in a speedy and efficient, high quality manner. Those are shown in blue. The second issue is ability to get things out. So that's green. And then survival, or what we're talking about more here, is like the immune clearance shown in orange. And so there's sort of a wide spectrum, even in the disorders that we understand better. And we don't really understand the molecular biology behind the neutropenia very well in any of these. It's also important to highlight the classic definitions, which most of us probably know by heart. The 1,000, 1,500, 500 to 1,000, less than 500 for mild, moderate, and severe. But remember, those aren't necessarily linked to infection risk. They only are linked that way if the bone marrow reserve is not robust. And so I'll show you a slide in a moment that kind of hits home into how we're reframing this classic definition of just a number to more thinking about the pools of neutrophils and what the reserve is within the marrow to indicate risk and whether or not there is a benefit to GCSF or prophylactic antibiotics. Also, as pediatricians, it's very important to think about the impact that prematurity or birth weight and age have on the neutrophil count. This is primarily important in the first 2 weeks of life, where the neutrophil count is much higher. About 3,000 is a lower ceiling as opposed to the standard 1,500, and then up to 2 years of life, where that 1,500 that we typically use becomes the proper lower norm, but really before that it's about 1,100. So just kind of having a context for the patient you're seeing. And then importantly, as we start to incorporate more personalized medicine, taking into account better proxies than race, the Duffy status, or rather the Duffy null status, where your FYA and FYB negative does directly impact your neutrophil count in your normal range. And so here's just a visual about the different pools of neutrophils. And I think we all think of the ANC as such a reliable representation of neutrophil count in the body, but actually it's just a tiny fraction. It's about 2% of the total neutrophil burden within the body. And the vast, vast majority is actually either in the storage pool, which can get easily depleted in neonates. That's why there's so much more at risk for infection, or in folks who have an overwhelming infection, with the second highest in the mitotic pool. So really kind of having a feel how you can infer, doing a marrow to get a sense of whether that bone marrow component, particularly that mitotic storage pool, is viable, is helpful to determine treatment. And if you're trying to decide whether or not an actual neutrophil number is clinically significant, the oral cavity is your best bet for physical exam. So these are some of the patients who have graciously shared images. You can see the gums, the gingivitis, it's red, it's briefy, it looks like it's gonna bleed at any moment, it's very friable. And you can see the tooth root is more exposed than it should be. It's a classic finding in chronic neutropenia, and then the oral ulcers. And then many of the times, I know it's easy to skip over looking at a peripheral smear or finding our pathology colleagues to look at the bone marrow, but both of these have visual cues that can really, really help hone in on the underlying IAI or bone marrow failure syndrome or other etiologies that require more active intervention. I just wanted to show those as sort of like a proxy, JP, as sort of additional ways to think about this intersection. For this patient, it's a little bit tricky. I don't know, Josh, did you want to make a final call on what you think about this variant? Because clearly, you know, depending on how hardcore you want to believe this variant, like it could be autoimmune due to the variant, or it could have been what I would call immune clearance or bone marrow suppression from a very significant infection.
So two things. Well, so sorry, just in a neutropenia, again, it just keeps popping up a lot. And I do wonder sometimes if there might be a role for CARD11 intrinsically in neutrophil homeostasis. It's obviously not going to cause, I mean, complete absence of CARD11 doesn't lead to, but we've seen neutropenia on a number of different, even some of the gain of function of folks as well. And it could be because it's autoimmune, but, you know, so I just would reserve a little bit of that space. Regarding this truncation, so one of the most important things, of course, would be from a clinical point of view to get lymphocyte proliferation and memory T and B cells. In not all, but in some of the more severely affected CARD11 dominant negative patients, lymphocyte proliferation was decreased, and T and B cell memory could be decreased. That could point you even more towards that this could be. It could be. The definitive thing to do is to take this mutation and transfect it into a cell with the wild type CARD11. This is done. My longtime collaborator and colleague Andy Snow does it. Andy is aware of this particular one and can make this eventually. And if he sees negative dominance, then you've got your answer. You can also look at primary cells and look to see if the signaling abnormality by flow looks similar to what you would expect in others. That would be strong evidence. But the only way to really prove it is this transfection. That's really the only way to prove any individual mutation is causal. That being said, I know that Andy has made a truncation not far away in a different patient who had a cadence-like presentation, and it was dominant negative. So there is a decent chance that this one could be dominant negative with variable penetrance and that one of the parents carries it.
Great, thank you both. So you mostly read my mind, so I'll flip through these next slides really quickly for the sake of time. But we touched earlier on autoimmune neutropenia, referring to that first bucket, the autoimmune neutropenia of infancy, where typically the bone marrow can produce adequate neutrophils during infection, and children are usually at minimal increased risks and do not require specific treatment, and it tends to spontaneously resolve. Next slide. First, Dr. Lopes, the next slide, if you can. So here it
for some reason it's like struggling to work, Delena, but I think it's moved now. This one,
okay.
right? Okay.
That's okay. Thank you. So here it's just showing that, again, there are multiple inborn errors of immunity that are associated with congenital causes of neutropenia, where there's an issue with production of neutrophils from birth, as opposed to secondary causes like peripheral destruction. So next steps, the patient and their parents are offered enrollment in a research study to validate the variant is dominant negative, but the parents opted out of research studies or further parental studies, which would be great to have, as we said before, for a watch and wait strategy. They felt like their kid had been through enough poking and prodding, understandably. And then we got Dr. Milner's final thoughts on the variant, which is what I was going to touch back on. But something I was also curious about is the natural history of cadence, and are there any prognostic factors that we know of? And how would you manage this patient in the medium to long term in terms of monitoring, and whether that be clinically or laboratory wise?
Yeah, we do have folks who can get pretty sick. Generally speaking, the ones who get sick and need a transplant, that tends to happen earlier in life, but earlier could be like, under 10. But you know, they're getting sick, they're getting infections early and all that sort of a stuff. The other place where people get sick is much later, lymphomas. So there have been a number of T-cell lymphomas, including cutaneous T-cell lymphoma, and it was fatal in several individuals, but you know, in adulthood. So I think that just monitoring infectious history is really the key. Looking for autoimmune disease of all sorts. Colitis has shown up in quite a few patients and difficult to manage. To the point, believe it or not, that we've actually treated some of these folks with JAK inhibitors successfully, which sounds kind of wacky, but there is a lot of immune dysregulation that's happening. It's not just immune, and the immune deficiency is not a big deal. For the most part, unless it is a totally big, treating with the with the suppressants doesn't make much of a difference. If the immune deficiency is bad, then one may want to consider transplant earlier, but it's not like DOC8 where we're much more likely that you would need to transplant. We don't really have a great idea with CARD11. I think the proliferation assay can be helpful though, because if you have no proliferation, that's probably more of a negative indicator. But it's going to then be on a case-by-case basis.
Thank you. So for our patient, he's had 2 viral URIs that were treated supportively, but no other infections. And of note, he did get 1 dose each of his MMR and varicella, and he tolerated those live vaccines well. So we went over a lot today, but the take-home points that I'm hoping you glean from this case presentation is that atopic disorders and neutropenia, despite being common, may be a part of a broader presentation of IEI. And CARD11 is one such gene that's implicated in immunodeficiency as well as atopic disease in the case of cadence. And genetic testing is now widely available and can help elucidate the diagnosis and the pathogenesis. Thank you very much for your attention, and I'll take any questions now.
And I know we're at the top of the hour, so I understand if a lot of you need to leave as well. Sorry, because I'm in video jail, so the Zoom is not allowing you guys to see me. But thank you everyone that's participated. I think it's like a great case for discussion, and for everybody that attended the webinar as well. I think these cases are really, really good in terms of how much they overlap several of our specialties and our common interests for clinical immunology. So I think it's a great case. If somebody stays behind, then it depends on the panelists, because I want to be mindful of their time. You can put some questions in the chat. Dr. Milner also shared his email for any workups for variants for CARD11. So feel free to continue reaching out about this, and we'll see you all very soon. Okay. Thanks, everyone.